Folks, I understand you are tired. Some of you are jet lagged. I am. I came all the way from San Diego, California, which is another side of the world. So this is me. My name is Igor, I-G-O-R, this is my name. And I'm a professor of psychiatry at the University of California, San Diego. And I have a pleasure of working with Kim, assisting her with ICUDDR. It's on. Yeah. Assisting Kim with ICUDDR. And I'm also a member of the MIT, Motivational Interviewing International Network of Trainers. And what I would like to present to you today is the way we teach students, the way I teach students. And I choose motivational work only as an example, because this is pretty much the model of teaching that I want to present to you, and you can actually apply it to practically any subject. So I choose MI because it's something closer to my heart, but again, this is just an example. So what I would like you to do, folks, imagine you are students. Just close your eyes for a second. Just close your eyes. And visualize yourself 10 years younger. So now you're students, okay? Just think about the time when you're students and pretend or try to make yourself feel like you felt when you were students. Okay, now you can open your eyes because you will fall asleep, but that's not what I mean. So you're a group of students, medical, social work, psychology, it really doesn't matter. And I will just teach you as if I'm teaching the regular university class in my university. That's exactly the way we do it. Okay, so today we'll have a conversation. And again, this is not a lecture. I don't want to be a lecturer because people don't learn much from lecturing. I really want to have a conversation with you, a dialogue with you, something that we can exchange with each other on the issue of motivation in general and on the issue of the strategies, what you can do to shift motivation, to assign, to assist people to do something about their motivation, because we all know in the field of behavioral medicine, even if you have, and actually even in the field of the physical medicine, even if you have the best medication in the world, if the person is not willing to take the medication, it doesn't do any good. So there is a lot of behavioral part involved. Okay. Oops. Okay, well, let's have a conversation. I presume you would agree that effective treatment of patients with any kind of chronic conditions, and substance use disorders is one of them, will require a certain level and certain number of behavioral changes. Will you agree with that? It's pretty clear, it's pretty obvious. Okay, so we need to work on the patient's behavior. Well, here's a $10 million question. Clearly, we do need to do something assisting clients, patients, whatever you call them, with this are the same people. Assisting them in changing their behavior, because we cannot fix people. I cannot force you to change your behavior. We need to assist people in changing, in doing something different. Well, here's a $10 million question. How are you going to do that? And another question is why people just don't change. Just think about it for a second. What we are facing in the area of substance use disorders every day is something that is practically goes against the common sense. Because the common sense tells me that having a first heart attack, and if you're a smoker, should be the perfect reason for you to stop smoking, right? The common sense tells me that spending a night at the police station being arrested for something illegal should dissuade you from doing anything illegal ever again, okay? Common sense tells me that when a woman found she's pregnant, that should be the perfect reason for her to stop smoking, to pay attention to the diet, to quit drinking, to go to the doctors, okay? This is what the common sense tells me. The common sense tells me when a person found that the alcohol consumption now is really impacting the life in a very significant negative way, that should be the reason for the person to stop. Isn't it right? Well, the question is, does it work? Well, it does for some. It does for some. But there is a significant proportion of people who continue the same behavior even despite the fact that they have already faced the negative results. And this behavior is ongoing and there is no change. That's an interesting question. Why? Why people continue doing, why even the negative results of this behavior typically are not enough for people to change their behavior? Isn't it an interesting question? Again, this is something that appears to go against the common sense and just know what people think. Okay, we have been trying to answer this question for decades. This is not a new question. Why people do not change their behavior, or why is it so difficult for a significant proportion of people to change their behavior from clearly problematic to less problematic, more functional? Over many decades, we developed a number of explanations why people don't do that. And these are very common and quite pervasive ways of answering this question. And I'm sure you've heard that before. I'm not telling you anything new. Well, some people think that people don't change their behavior because they don't know that they have a problem, meaning the knowledge is missing. They don't change because they don't know that there is a problem, okay? There is another way of answering this question. Some other people think that people don't change their behavior because maybe they know there is a problem, but they don't have skills to change it. So the knowledge is there, but the skills are not. There is a pretty common belief system, particularly in criminal justice environments, that people don't change their behavior simply because they don't care. So the knowledge might be there, the skills could be there, but the emotional component is missing. Okay, I don't care about it. Have you heard these kind of things? These are pretty common ways of answering the question why people do not change their behavior despite significant negative consequences. Well, I have a good news for you. If these answers to the question why are true, then you absolutely don't need me. Because the solutions could be very simple. If the knowledge is missing, well, give people knowledge. Get a bunch of methamphetamine-dependent individuals for 45 minutes class. Tell them how bad it is, and they should stop because you just gave them knowledge, right? Okay, if skills are missing, give them skills. Get a bunch of people who are unemployed, give them a training how to write job application, how to dress for the job interview, just give them skills, and that will do it. If the emotional part is missing, if people just don't change their behavior because they don't care, well, give them help. Make them uncomfortable enough. Put them in prisons. Scare them. Inflict certain amount of pain. That should certainly do that, right? Well, and we have done it. We have been doing this kind of things for decades. And we all know, you're all professionals. You're all experts in something. We all know how ineffective these strategies are. Let me show you something.
Dr. Switzer?
Yes, come in. I'm just washing my hands.
I'm Catherine Bigman. Janet Carlisle referred me.
Oh, yes. You're very belonging.
Yes, that's me. Should I lay down?
Oh, no, we don't do that. Just have to. And let me tell you a bit about our billing. I charge $5 for the first 5 minutes, and then absolutely nothing after that.
That sounds great. Too good to be true, as a matter of fact.
Well, I can almost guarantee you that our session won't last for 5 minutes. Now, we don't do any insurance billing, so you would either have to pay in cash or by check.
Okay.
And I don't make change.
All right.
that you wish to address?
Okay, well, I have this fear of being buried alive in a box. I start thinking about being buried alive and I begin to panic.
Has anyone ever tried to bury you alive in a box?
No, but truly thinking about it does make my life horrible. I mean, I can't go through tunnels or be in an elevator or in a house, anything boxy.
So what you're saying is you're claustrophobic.
Yes, that's it.
All right, well, let's go, Catherine. I'm going to say 2 words to you right now. I want you to listen to them very, very carefully. Then I want you to take them out of the office with you and incorporate them into your life.
So I write them down?
Well, if it makes you comfortable, it's just 2 words. We find most people can remember them.
Okay.
You ready?
Yes.
Okay, you're there.
Stop it.
Yes, S-T-O-P, new word, I-T.
What are you saying?
You know, it's funny. I say 2 simple words, and I cannot tell you the amount of people who say exactly the same thing you're saying. I mean, this is not Yiddish, Catherine. This is it. Stop it.
So I should just stop it.
There you go. I mean, you don't want to go through life being scared of being buried alive in a box, do you? That sounds frightening. Then stop it.
I can't. I mean, it's been with me since childhood.
No, we don't go there. Just stop.
So I should just stop being afraid of being buried alive in a box.
You got it. Good girl. Well, it's only been 3 minutes, so that will be $3.
But I only have 5. So.
I don't make change.
I guess I'll take the full 5 minutes.
Fine. All right. Well, what other problems would you like to address?
I'm bulimic. I stick my fingers down my throat.
Stop it! Don't do that.
But I'm compelled to. My mom used to call me fat.
No. We don't go there. No, we don't go there either.
But my horoscope did say.
We definitely don't go there. Just stop it. What else?
Well, I have self-destructive relationships with men.
Stop it! You want to be with a man, don't you?
Mm-hmm. Yes.
Stop it. I wash my hands all the time. A lot of germs. Yeah, don't worry about that.
I'm afraid to drive.
Well, stop it! How are you gonna get around? Get in the car and drive, you kook.
Stop it! You stop it! I don't like this. I don't like this therapy at all. You're just telling me to stop it.
And you don't like it.
No, I don't.
So you think we're moving too fast?
Yes. Yes, I do.
All right, then let me give you 10 words that I think will clear everything up for you. You want to get a pad and pencil for this one?
Right.
You ready? Right here are the 10 words. Stop it or I'll bury you alive in a box!
Okay, this is what in many instances the interaction in addiction treatment field look like. Just stop doing drugs and you should be fine. Particularly, again, if you go to the criminal justice settings and observe the interactions within the criminal justice settings, this is pretty common. Unfortunately, it is not uncommon even in the medical settings, where people who are not particularly trained, specifically trained in addressing substance use disorders, the level of their understanding tells them, well, just stop using drugs and you should be fine. Which, again, it does make sense. In science, though, not everything that makes sense is correct. Well, this is one of these situations. So let's experience. I want you to think right now about something real in your life, something real that you are struggling with, something that you would like to change. A part of you wants to change it, a part of you tells you, well, keep it as is. So something that you would, maybe you would want to change, but you're kind of ambivalent and hesitant. Everybody has something like that. Okay? I would suggest you not to think about something super dramatic like killing your boyfriend. No, something that you will feel comfortable sharing with at least another person. The examples that typical, common human experiences is losing weight, being on a diet, exercising more, spending less time on the internet, stop yelling at your kids. I mean, these are the typical things that people are considering. So think about it. You got it? Okay, very nice. Okay, here's what I want you to do. We don't have any opportunity for any movements around this room because the seats are fixed. So I want you to turn around to the person on your right, just make a partner, find a partner. On your right or on your left, find a partner. Okay? In any way you can do that. Okay, just find a partner. Usually in real trainings I have moving chairs so people can move. Okay? Please, folks, don't dissociate from me, not yet. Okay. Give yourself a number. Who's number one, number two? Random. Okay. Number ones, you will be the counselor. Number twos, you will be the client. And actually, you will do two steps, so you will experience it both ways. Counselors. Now, I need your attention. Counselors, you will see the screen, on the screen. I don't want you to do anything other than what you will see on the screen. Don't do any gestalt therapy, psychoanalysis, exotic, psychodynamic, whatever. No, just see what is on the screen, just follow the screen and talk to the person. Okay, is that clear? It's pretty simple. All right, go ahead. And I will give you 5 minutes max. Go ahead, 5 minutes. You have 1 more minute to wrap it up. Okay. All right, folks. Here's what we'll do next. Please switch your chairs. Physically, just switch your chairs. Okay. Do I have your attention? Folks, I'm a little bit pushing you, and I understand that. We just have limited time, and you are tired. So it's not the best combination. Okay, so now those of you who are counselors, you are clients, and those of you who are clients, you are counselors. You will be doing exactly the same thing. You will intervene, the counselors, you will intervene. This time, the script will be different. Again, I'm not asking you to do anything other than what the script tells you to do, okay? Let's just have this experience, and then we'll process what exactly the experience was like. Here's the second script, and you have 5 minutes.
Yeah, that's it. Yeah. That's why I have the title. Yeah, because sometimes you don't know something. Days long. Next day, 70. So, and this is real, right? This is real. And you will more agile. That's it. Something's better. Who pays for the session? Who pays for the session?
I know. Okay, folks. I hope we understand the goal is not to solve all of your problems. I just wanted to give you an experience of two different counseling styles. The style one, that is more like a traditional counseling. Here's what you got to do, go ahead and do it. The style two, that is quite different from the traditional counseling. If I ask you to think, I'm not asking you to answer. If I ask you to think, which of these two different styles is more likely to move the person toward actual change? The second. For a variety of reasons, I just wanted you to experience it, not just talk about it, to experience it. Okay. You're all familiar with the will of change. I'm not going to stop that. The change goes through a predictable number of steps. And this is something for us just to remember. The will of change and the process, the trans-theoretical model of change is not a part of the motivational interviewing, but just for all of us to, I want to remind you that the change doesn't happen overnight. And people go through a cycle, through predictable steps in the process of change. And this is a very interesting and quite important question. Because here is my son. This is my son. He was little. By the way, he's sitting right there. He's my son. And he is very ambivalent about jumping from this tree. A part of him wants to do that. A part of him tells him, no, it's not safe. Okay, he's very ambivalent here on this picture. And literally, a couple of months later, these are both of my sons. You know, they're almost flying. So apparently, you see, there is clearly a behavioral change. There is a mental and emotional process that these kids went through that helped them actually to make a decision, should I or I should not? From the ambivalence, from the hesitation, or what we in science sometimes we call it pre-contemplation or contemplation, to actual action. It doesn't happen immediately. People go through a process. Well, that's exactly the interesting question. What is the process? What is the process of the ambivalence? And what is the mechanism that actually can create some motivation for action? In order to do that, first we need to define what motivation is. Because if I ask 100 people on the streets, what is your definition of motivation? You will get probably 100 different definitions. And it's really operationally, it would be very difficult to teach or to train or to discuss anything unless we are clear what the definitions are. We're talking about the same thing. Well, here is the definition of motivation that I prefer. Again, I'm not imposing it on you. This is what my preference in terms of the definition. Motivation is the probability for an individual to initiate and maintain desirable behavioral changes. And the key word here is probability for two reasons. Probabilities are constantly changing. So when you play a slot machine in Las Vegas casino, with every movement, the probability to win is different. So the probabilities are constantly changing. So is the motivation. Human motivation to do or not to do things change in minutes. And it's highly dependent on the interaction with another person. So that's the first reason. And the second reason, the probabilities are measurable. So is the motivation. So the motivation, again, let me repeat the definition, is the probability for an individual to initiate and maintain desirable behavioral changes. Okay, now, you remember you just thought about something in your life that you are ambivalent. So let's define ambivalence. Ambivalence means having two contradictory thoughts about the same thing. Should I or I should not? Folks, ambivalence is normal. Being ambivalent about simple things is normal. This is a part of normal human behavior. There is absolutely no pathology in being ambivalent. I will give you an example right now this second. If I ask you to switch the wrist you're wearing your watch from left to right or another way, just do it. Do it. Go ahead and do it. Okay?
What about those who are not wearing?
Okay. If you don't, just trust the ones who do. Folks, ambivalence, why I'm talking about ambivalence. Ambivalence is exactly the material that the motivational interviewing works with. This is the material that for us to work. This is quite important for me because I really don't want you to think that motivational interviewing is a panacea or it can solve every problem, clinical problem in the world. This is not true. MI is a very effective way of addressing ambivalence in people who are ambivalent. So if you see your child running across the traffic, this is not a good idea, good time for motivational interviewing. Okay, you need to take care of business first. If you have a patient who is in alcohol recovery for 25 years doing well, there is no reason to bring back the ambivalence. What is not that good about being sober? It doesn't make sense. Okay? Just maintain it and that's it. So motivational interviewing is a very specific counseling style to address the common problem of ambivalence in people who are considering change. Does that make sense?
Yes.
Very good. All right. Here is, folks, one of the key things, and this is something that I really want you to remember. If there is anything smart that I said so far, probably nothing, but that will be probably the first thing. We often, in clinical practice, we often use the expression of resistance. Do your clients resist?
Yes.
They do. Do you resist?
Yes.
We all do. It's normal human behavior. It's normal human behavior. We often use the words resistance and ambivalence interchangeably. But these are two different things. And this is something quite important for me, and it might be for you too, to understand the essence of the motivational work and the essence of the motivational interview. Resistance is the ambivalence under pressure. If you're ambivalent, you're hesitant, and I start putting pressure on you, you will become resistant. Make sense? In other words, this is Ambivalence is a reflection of my relationship with the problem. Resistance is a reflection of my relationship with you. You understand the difference?
Yes.
It will take two to resist. You folks will have a hard time arguing with me if I don't argue with you. You will survive 10 seconds. But there is something that is quite important for our understanding of clinical processes and the motivational interviewing. Would you help me? Okay. What's your name, sir?
Bola is my name.
Let's see. Bola?
Yes.
Okay. Give me your pen, please. You exercising?
Yeah.
Okay, that's a strong guy. He's much younger. Okay. Bola?
Yeah.
Let me ask you a question. Why did you push me? There must be a reason. Well, because I pushed you. Right? Is that the reason?
No,
Why did you push me?
you were the one pushing me.
Right.
Right.
And you pushed back.
Yeah, you asked me to resist.
Thank you. Folks, please pay attention. I put pressure on him and he immediately responded with pressure back. Right away. Had I given him some time to think about some other strategies, there are millions of other ways to do that. For instance, if he steps aside, I will fall down. But he didn't. And nobody would have done. Why? Because from the early childhood, we are conditioned to respond to pressure with pressure to pressure. It's a normal human behavior. It's normal to push against something that pushes against you. This is a spinal cord reflex. We all do that. It's a normal human response. I put pressure on him, he immediately put pressure back. This is what happens in clinical practice.
Seeking balance.
That's, well, he's seeking balance. This is the second Newton law in mechanical physics. It's a kind of normal behavior, even from the physical perspective. Okay. The issue here is that if I continue putting pressure on him, he will continue putting pressure on me. And this, from this point further, this has nothing to do with clinical interaction. This is a boxing match. This is wrestling between the two of us. And unfortunately, this is what commonly happens in addiction treatment. I put pressure on the client and I get pressure back from the client. I tell the client what to do. The client tells me, no, this is all BS. It's not going to work. You know, BS is behavioral science. Okay? It's not going to work. And we go back and forth. This is like a ping pong. We are wasting time. We are raising the resistance more and more and more and more. Okay. So let's define motivational interviewing. The motivational interviewing is a counseling style, which is quite different from traditional counseling. It's a counseling style. It's a collaborative, person-centered, and quite directive counseling style that will help people to address a common problem of ambivalence in any kind of behavioral therapy, including substance use and addiction medicine. Okay? With MI, we are addressing a very common problem that we are facing every day, the problem of ambivalence. Okay. Once again, the assumptions in motivational interviewing are a couple. Motivation is very dynamic. It changes very quickly. Being ambivalent is normal. There is nothing wrong. This is not a symptom of any pathology. And the third, which is quite important, most people, even very dysfunctional, most people know what to do. Most people have very good ideas in their head what needs to occur to change their life. They don't necessarily follow through. But most people have good ideas. What will happen if me, as a traditionally trained counselor, if I start telling you as a client, here is what you gotta do, guess what will happen? I'm telling you something that almost for sure you have already considered. And I'm telling you something that maybe you have already tried and it didn't work. So in fact, the message I'm sending to you is you are incompetent. And I will get a resistance back immediately in a second. This is probably the fastest way to make somebody resistant, is to start telling the person, here's what you gotta do. And unfortunately, most of our traditional behavioral, psychological, and psychiatric training, in fact, is based on the idea that you have a patient, you have a client who came to you with a problem, and now you're telling the client, here's what you got to do to get better. Well, for some it might work, but for people who are ambivalent, the second I will start sending this message, here's what you got to do, rest assured, you will make the person, even the person who is not resistant, you will make the person resistant right away. There is a different way to do it. In motivational interviewing, we go through the fundamental processes. And the first process is engagement. Folks, it's pretty simple. Again, I'm not telling you anything like rocket science. This is all simple. If the person is not engaged with you at some level, no other conversation makes sense. You're wasting time. And it's not any different. This is not any different than in real life. If you're interested in somebody, in any way you're interested in having an interaction with another person, it could be intellectual interest, it could be romantic interest, it could be sexual interest, it could be any kind of interest. First you want to engage the person in a meaningful conversation, right? So when you're, forgive me, but we are adults, except my son, when we are romantically interested in somebody else and you approach the person for the first time, we are not talking about having sex, right? We are trying to engage the person into a meaningful interaction. And when we get sufficient engagement, we proceed. We may succeed, we may not succeed, we just proceed and we do something else. And from the engagement, we're trying to find out what is the focus of our conversation, what the target behavior is. Most likely it will change over time. But we need to negotiate with the client. What is it that the client feels like a priority? And this will be our target behavior. Again, in counseling, if we don't know what the target behavior is very specifically, we're wasting time. And the target behavior has to be negotiated with the client in a very specific language. And from the focusing, we are getting into the evoking stage. And the evoking stage is, so what do you think might help? What have you done in the past that worked? Okay? How do you see your life happening if you make this change? What do you think will happen if you don't make the change? So we're evoking the ideas from the person instead of telling the person what to do. And the last phase or the last process is the planning. The first three processes are circular. We engage and re-engage clients every time we meet. Engagement in clinical counseling is like taking a shower. We do it every day. That's what we do every time we meet the client. Focusing will be another circular process because we'll do it every day, every session, because the focus, the target behavior will change. The evoking, again, we will continue doing it in a very circular way. The only process that is linear is planning. You cannot do any planning without sufficient engagement, without clear target, what the target behavior is, without clear evoking, eliciting from the client what are the client's thoughts, what might help. And right after that, only after that, we can do some planning. In other words, when you see the client for the first time in your office, asking the question, so what are your plans for the future, doesn't make any sense. What if the client doesn't have any plans? So now the process in the client's head is, oh, I'm supposed to have a plan? Now you make this client extremely anxious. And you cannot work with an anxious patient because the more anxious the person is, the less rational the person is. And you really want to work with somebody who's rational. Does that make sense? Yes. Good. All right. In the motivational interviewing, we have something that we call it the spirit of MI. And the spirit of MI is, first we need to know what is the target behavior. Imagine you have a woman as a client, a woman who is using heroin or amphetamines or also alcohol. And you're working as an addiction specialist, you're working on substance use disorder. But this is the woman with significant traumatic experience in the past. Okay? So now what would be your target behavior? That's a really good question. Probably the initial couple of sessions before you build some engagement, you will go with whatever the woman said. But when you did establish some engagement at a certain level, well, you probably will start focusing more on the fuel for the substance use behavior. In this case, focusing on substance use, forgetting the traumatic experience in the past, doesn't make much sense. It's like giving Tylenol or aspirin for somebody with a brain tumor for pain. Well, the pain will go away for 20 minutes, and then the problem is there. You follow me? Good. We also need to remember the issue of empathy, and I will define empathy for you. We also need to make sure that we are eliciting from the person as much as possible. Folks, let me stop here for a second. I presume that most of you have some level of certification, or you have diplomas, or you're maybe PhD level. So you have some university formal education. I'm a physician. I'm an addiction psychiatrist by training, and I'm a physician. My training as a physician gave me the expertise in finding the symptoms, putting them together as a set of symptoms. We call it a syndrome. Then from syndrome, I will establish some differential diagnosis, then some provisional diagnosis. I will do some tests, the MRI, blood work, something else, and that will get me closer to the final decision about the diagnosis and then treatment strategy. That's what I have expertise in. Do I have expertise in the patient's life? No. Not at all. Do I have expertise in your life? No. Is there anybody else? Who is the expert in your life? You. Because you're with yourself all the time. Okay? You're having your dialogue with yourself all the time. Unfortunately, we have been trained, I don't know about your school, but in most American schools, we have been trained to believe that as trained and certified or licensed physicians, we have expertise over people's lives. We don't. With all my diplomas on the wall, and I have many, I'm a professor of psychiatry at a major university, one of the best in the world. I don't have expertise in the patient's life. I don't. It sounds like a bad news, but in fact it's not. Now, for some reason, I have this patient sitting in front of me in my office, bringing this expertise, making it available to me, and that would be stupid not to use it. That's why I will be evoking from the patient, tell me more about yourself, I'm curious. Tell me, let's not talk about substance use. I understand this might be something problematic, but I need to find out what kind of person are you? You're an expert yourself, tell me more about it. Tell me more. This is what we are trying to prevent is the premature focusing. The premature focusing on substance use much before we know who the person is. What is the story here? Okay, and now we're already jumping into the focusing. What else? Yeah. Right. Here is, in terms of the giving advice, you remember what I just said, that most people have some good ideas, what needs to occur. So telling them what to do or giving them advice is not the best idea. At the same time, I do appreciate the clinical realities. And in real life, sometimes you do need to give people advice or share information. So it seems like there is a contradiction here. Well, there is a strategy here that you may try to use even tomorrow morning. If you feel like you absolutely need to give advice or share information, there is a strategy, we call it the motivational sandwich, or EPE, elicit, provide, elicit. And this is the way you do it. Before giving any advice, you ask permission. Do you mind if I share with you something? Most likely the answer will be a yes. If the answer is no, then don't. The next step is, before doing that, what is your understanding of alcohol use disorder or alcoholism or pregnancy or diabetes or medication or whatever is the problem? What is your understanding? And then, forgive me, shut up and listen. Even if the person tells you absolutely bizarre things, do not argue, just listen. Give the person time to share the person's perception, what the person thinks about it. Then you ask again, do you mind if I share with you a couple of thoughts that might be useful? The answer is yes. Now, from this point further, you can share any information, you can give any advice, you can say anything you want. And at the end, you ask again, Has anything changed in your understanding of the problem after we have this exchange? This way, you will share information, you probably will be able to give advice, and you will avoid making the person resistant. Clear? Well, this is the way, this is a strategy that might be helpful. Try it. Even if it doesn't work, nobody's going to die. It's pretty safe. Yes? What?
It's the truth of the thing. Practice, I've discovered one thing. You give the client information you already come out.
Of course.
Actually,
So actually you're confirming what I just said. Yeah. You're right. It's a very common clinical experience. Very few people pay attention to that. You clearly did. But unfortunately, very few people do pay attention to that. You are absolutely right. Yes?
Can I just add something quickly?
Sure.
So in Rwanda, when you're training young psychotherapists, they often fall into the trap of thinking they have to provide the answers. Because in Rwandan culture, people go to you for advice, and they will say, "Tell me what to do, doctor." Tell me
It's
what
not
I should
uncommon
do."
even in the US counseling. Yeah.
And it's very cultural.
Yeah.
And,
Well,
and you fall into the trap. So,
yeah.
And then if you do tell them, or you even make suggestions, they'll say, "Oh yes, yes," but it's a very passive aggressive thing. They have no intentions of doing what you just said.
Yeah.
So,
I'm not familiar with the culture that you're referring to. You're the expert in that. I'm not. But I'm telling you that I'm training young doctors, psychiatry residents. These are young physicians in their psychiatry training. They do exactly the same. They do exactly the same. So it's a part. It looks like it's kind of cross-cultural problem with the training, how we train counselors and physicians. We're probably not doing a good job training them correctly. You're right. Okay. So when the person is resisting, false. Our clients, you said they do resist, we resist as well. If the person becomes resistant and you sense it, you see it right away. In fact, this is a good sign for you. The person tells you, don't do it. Okay? Stop it. The person, when you see that the client is getting more and more resistant, this is the message to you. Do not do it. Shift the direction. Do something else. You may get back to this issue again in 2 weeks, or maybe never. But this is it. Folks, how many of you are drivers? How many of you drive cars? Do you use GPS navigators in your cars? But even if you don't, you know what it is. Yes. Just think about it for a second from the behavioral standpoint. You got into the car, you dial the address, you said to this device, here's where I want to go. And then now you drive. What this device, what does it do? It doesn't talk much, right? But it monitors your behavior every second. Because you said, here's where I want to gonna go, and the device is helping you. It doesn't talk much, but actually it pays attention to your behavior every second, monitoring it very carefully. And at some point, the device will tell you, okay, in 500 meters, make a right on the 5th Avenue. For whatever reason, you decided, no, this is not what I'm going to do. I have a better way. I know better. I'm really happy. So you have a second thought. You decided, no, I'm not making a right. I will continue straight, and you do that. Does the device get emotional? No. Does it tell you I said right, stupid? No. No. But what does it do? Immediately, this electronic machine recognizes that you're resisting the instruction. It doesn't get emotional. It will change the strategy right away. It will recalculate the directions, and it's still helping you. And it will continue working with you. If you continue making mistakes and not following the instructions, this device continues working with you, trying to assist you to get to the place that you said you want to be. This was your choice, okay? This is exactly the essence of a professional, good level, motivational interviewing counseling. You're paying very close attention to what the person is doing. And you're staying neutral and utilizing some of the tools and skills that I will show you in 5 minutes. But before doing that, I want you to see this.
Okay, so we've talked about your labs, and you seem to have a good grasp of that. And we've talked about the different options for medicines. And I think you'll agree that the last option we talked about it is the best way to go in terms of the financial cost of it, the side effect profile. And so I'd like to just go ahead and write you the prescription.
I'm not quite ready for that, if it's okay. I'm just not comfortable yet. I'm still not convinced. I'm not sure I want to do this. I mean, this is like a big step for me. And I want to know, are there alternatives, for example?
George, we've been through this. We've talked about the alternatives and
yeah, but the alternatives are all sort of like Western medicine. Is there like Eastern medicine I could use?
You've been on the internet again, haven't you?
Yeah, I mean, it's a world out there.
Yeah. Well, it's a big, confusing world, and I'm glad you came here, because really you can spend a lot of money and a lot of time out there and not get what you need. We've talked about your lab values, and we've talked about the benefits of taking this medicine, and as we weighed out the costs versus the benefits, it seems really clear to me.
Okay, let me just ask without being too sensitive here. Should I ask for a second opinion? Will that make a difference?
You can ask for a second, third, and fourth opinion. They're all going to tell you the same thing. It's not subtle. I mean, at this point, the numbers are high, and the reasons to take medicine are clear.
I guess maybe the thing that I'm not making clear is, for myself, is just the whole idea of spending the rest of my life stuck on a medicine. I watched my parents go down that road. It just was one medicine after another, and there they sat. Next thing I knew, it was just constantly running to and from the pharmacy, and I'm really not too excited about that for myself.
Well, I don't blame you for not being excited about that picture, but the alternative picture, I think, is a lot less exciting. And if it takes a pill to keep you alive and relatively healthy as long as your parents have been, I think that pill is probably the option for you.
Well, let me try something else. Is there something I'm not making clear about? Is there something I should be thinking about before I take this step?
Thinking isn't going to lower your cholesterol, unfortunately.
I'm stuck.
Well, you're not stuck, because we've got this medicine, and the medicine.
Oh, I'm stuck.
Yeah.
That's the way it comes down. It's like it's a blind alley, no choice. You got this to do. That doesn't make me feel comfortable.
To be perfectly honest, if I have a choice between you being comfortable and you having a healthy cholesterol, I'm going to take the second choice.
Will that make me comfortable?
Well, at that point, we'll have a chance to talk about it. I'm worried that if you don't take this medicine, we won't have a chance to talk about it, because your numbers are high. They really are.
Well, I guess.
I'll go ahead and write out that script.
Sort of like getting a speeding ticket, isn't it?
Well, hopefully a little less painful, a little more helpful.
Yeah, all right.
Okay, folks, what is happening between these two people? The target behavior is clear, medication. Let me ask you, is there anything that the doctor factually, what the doctor said, that is incorrect factually? No. The doctor, from the factual perspective, he was perfectly correct. What is happening between these two people? Well, this is a boxing match. They're wrestling with each other. Now, let me ask you something else. Whose agenda is in the middle of this conversation? The doctor's agenda. We don't know what will happen next. We don't know if the patient will start taking medication or not. But if I ask you intuitively, what do you think? How likely it is that the patient will start taking this medication? Doesn't feel likely to me. Okay. Now, one of the reasons why it doesn't seem likely, because the doctor doesn't have any empathy. The doctor's agenda is in the middle of the conversation. Factually, he's accurate. Stylistically, he's just building all sorts of resistance in the patient. This is not the way to work on the ambivalence, because the patient is clearly very ambivalent. Empathy, in fact, let's define empathy. Empathy is a trainable skill. I mean, some people are more empathetic than others. Some people are kind of naturally empathetic, but you can train people in empathy. Empathy is the ability to do two things. One is to understand the clear ability to understand the source of the client's thoughts, emotions, or actions. And two, to convey accurately back to the client that you understand him or her. Empathy has nothing to do with agreeing or disagreeing. You may totally disagree with the client and still be empathetic. Empathy is just ability to understand. Yes, I understand what the source of this. Where is it coming from? Empathy is not specific for motivational interviewing. In any kind of effective professional counseling, the empathetic skills are prerequisite. Even in human interactions. I mean, if you go to somebody's house for the first time, invited for dinner, well, you don't tell people how to rearrange the furniture, right? You don't do that. Even if it looks ugly, you still don't do that. Because that will be the end of the interaction. With curiosity, I'm trying to understand what is the rationale for people to have it this way. There must be some. People don't do things just because, okay? So the empathy is, in a way, I really want you to pay attention to this metaphor that I came up a long time ago. Empathy is like gas in your car, like benzene in your car. It doesn't define where are you going, whom are you going with, when are you going to stop for a cup of coffee. It doesn't define any of this. But you're not going anywhere without it. That's what empathy is. Empathy, again, is not specific to a mind. Empathy is a prerequisite as a skill for any kind of professional, effective professional counseling. Here is what I want you to see. Exactly the same two people discussing exactly the same issue, but this time the doctor's style is different.
And you believe it or not, you're not the first guy that's told me his wife made him come in to talk about this stuff.
I don't understand. Why are they so into this medicine stuff?
I don't know. I wonder if they're worried about you.
Let's stop and think about it, I suppose. There's nobody else that can change the lights on the ceiling. Well, here I am. What do I have to do?
Well, I'm hoping that we don't need to talk about it in terms of what you have to do. I'm hoping that from our discussion before about your cholesterol and the role that medicine might play in lowering your cholesterol, that you can make an informed decision about your treatment options, and we can go from there.
But I got to tell you, my head swims when I think of all the options.
Yeah.
I mean, an informed decision is one thing. You get this much information. You probably already know I checked out the internet.
Yeah.
And it's just like, whoa. I could lay out in a cornfield with a cone hat on, and it would maybe lower my cholesterol, they say.
There's a million options out there.
Well, so where do I go? Should I seek a second opinion?
Yeah. Well, let's see what we can do in here today, and then you'll know that at any point in time you can seek further opinions and consultation if you think that'll make it easier.
I don't want to make it sound like I don't trust you.
Okay.
And I do. You've been good so far. But this is a big decision on my part.
It is.
And it's sort of terrifying. It's sort of like I'm becoming mortal.
Yeah.
I don't like that.
No, I hear you. It's scary to think about things that might shorten your life, and that's really what we're talking about here. And the high cholesterol, as we've said, is a pretty important risk factor for pretty serious disease, and that's why we're talking about serious treatment options. Like you said, the medicine's not fun. It's not fun to think about having to take a medicine for a long time, or even maybe for the rest of your life. And I wouldn't want to suggest that as a treatment option if I didn't think it might be helpful for you. But like you said, there are lots of other options. Let's pick an arbitrary number. Let me have you tell me just briefly about the 3 options that you're thinking about right now.
The cornfield with the aluminum cone cap.
Let's keep that on the list.
Exercise.
Okay.
Diet. And more exercise.
Okay. So exercise seems like a really good option for you.
Yeah, I need it. I could use it. Good.
Yeah.
If I worked out twice as much, would it help?
I think it certainly would help. And I don't think you'd find a doctor in this office, and you certainly didn't find one here today, that's going to discourage you from doing exercise. I'd love to talk to you more, and I've got some information that might be helpful for you about the types of exercise that you can do that would be most helpful. And even if you end up taking the medicine, I think you should seriously consider doing that exercise as part of your treatment plan.
But you still think the medicine should go along with it?
From what we've seen thus far, the medicine seems like an important part of the treatment plan. I'm not going to be taking the medicine. You will be taking the medicine. And so my job today is to make sure that I've answered all the questions that you have, so that if in fact I do write this prescription, we have a good sense that you'll give it a try, take the medicine, and see if it helps.
If I consent to you writing the prescription, will you tell my wife I was a good patient?
I think I'd probably go ahead and tell her that you were one of the better patients.
Okay, you see exactly the same subject, exactly the same two people, different style. If I ask you again the same question, which of these two interventions is more likely to result in a desirable behavior? The second one. Because now, not the doctor's agenda. He's in the middle, and the doctor is quite empathetic. And doctor is using some of the skills evoking from the person, making sure that the person is in the driver's seat. The person is responsible for the decisions. Because we are responsible in most instances for our decisions for ourselves. Okay? So the second interaction is much more likely to bring us closer to the preferable, desirable behavior. Okay. The motivational interviewing is not a specific tool for substance use disorders. The MI is probably the second most studied non-pharmacological interventions in the world. Probably there are more randomized clinical trials on cognitive behavioral therapy. And MI is probably the second most studied. Hundreds of clinical trials showing that actually this way of approaching ambivalence is quite effective in a variety of problem areas: weight control, criminality, substance use, nutrition. So this seems to be a common pattern in addressing ambivalence regardless of what the target behavior is. Medication adherence. So MI has been found really in both adults and juveniles. There are some differences in terms of some tools with juveniles, but this strategy appears to be based on the data, based on a large number of science and research, appears to be by far more effective with ambivalent clients than the traditional do it or else kind of approach. In terms of the skills, there are two parts of the motivational interviewing competence. One is the relational part of the MI, the respect for autonomy, the empathetic skills. This is something that you can use across the board with any kind of client, because this is something that might be, for sure, based on research, will be more effective than just traditional, I'm the expert, you are the client, do it the way I said, and you will be fine. So this is the relational part of MI that you can use it with any client at any time. There are some technical skills in the MI that, depending on the context, you may or may not use. It depends on what is it that you're after. The technical skills, the acronym is ORS. This is just the acronym. This is not the sequence. This is not the order of importance, just an acronym. Open-ended questions, affirmations, reflections, and summaries. These are 4 fundamental skills in motivational interviewing. If you really want to build some mastery, some proficiency in MI, you need all of these 4. I've heard it many times from people who are not really well trained in MI. Yes, we are doing motivational interviewing because we are asking open-ended questions. Wonderful. If you use just one or, you will be going in circles. Okay, that's what happens. This is why we need all 4 to be proficient, and we use them when it's appropriate based on the clinical context and the clinical situation. Open-ended questions. The difference between open-ended and closed-ended questions: open-ended questions do not limit the opportunities for response. Closed-ended questions, they can be answered yes or no, or even if you ask the client, on a scale 0 to 10, how bad is your headache? This is a closed-ended question because you limit the responses. Open-ended questions actually give the opportunity to the client to come up with a narrative. False. Closed-ended questions and open-ended questions, they're neither good nor bad. These are just different questions. They serve different purposes. Closed-ended questions are fact-finding questions, and you do need to find facts. They have nothing to do with the client's agenda. They have to do with your agenda, yet they're still important. Open-ended questions, they will serve the client's agenda. But again, depending on your goal, you may ask any question you want, but you need to be mindful. What is it that you're after? What is it that you're doing here with this question? Whatever question it is. There are some of the examples of open-ended questions. Open-ended questions usually start with what, how, tell me about it, help me understand it, describe, please describe. These are the open-ended questions. Closed-ended questions usually start with do you, can you, have you, did you. These are the questions that can be answered yes or no. And that could be the end of your conversation. There is a special kind of questions that I have a particular slide. This is what I call death questions. If you want to ruin a relationship, this is probably the best way to do it and the fastest. And here are the death questions. Why don't you? Why can't you? Why haven't you? What keeps you? Da, da, da. Folks, even not in clinical session, if you want to get rid of problematic relationship, this is what you want to do. Start asking these things. This will do it in 5 minutes, all right? So in clinical practice, because we are professionals and we are trying to build some of the skills, I would suggest to you, if I may, avoid this type of questions. Unfortunately, they're very common in clinical practice, and I observe it in counselors around the world, in the US, and in different countries. These are pretty common. This is what's something that will actually kill an engagement, even if you already build some form of engagement. By doing that, we will kill it right away. Here's what I want you to do now. Could you stand up? I will read you questions. I will read you questions. You will listen to questions. When you hear a closed-ended question, you will snap. When you hear an open-ended question, you will clap. Okay? So closed-ended question, snap. Open-ended question, clap. Clear? On top of that, I will ask you to turn around and face this wall. Okay? And the reason for me to do that, because we need to start training our ear in listening, selective listening. Okay, let's do that. Why don't you just tell him to leave you alone? Are you going to confront him? Let's do it again. Are you going to confront him? How often does he do that? Is he drunk when he calls? Why do you think she does it? Why do you think she does it? Do you feel like hurting her? Have you ever talked to him? Can you think of a time when he did behave better? Does it happen often? What else might you do? What do you think might help? On a scale 1 to 10, how mad does he make you? Why are you telling me this? Don't you think it's time to stop? Does she remind you of anyone else? Is this an open-ended question? Okay, please sit down. Please sit down. You see, folks, how difficult it is sometimes. It's easy to talk about it. It's not that easy to recognize. So one of the things we need to do is to train our ear, our listening skills, in listening specifically. I mean, good listening skills will show to everybody that you're just a good person. You don't need me for that. You're already good people. I'm talking about clinical skills in selective, careful listening, exactly the way the GPS works in your car, monitoring your behavior and paying attention every second to what the hell are you doing. Okay. All right. A stands for affirmation and acknowledgement. Affirmations, the meaning of affirmations is something that we know for hundreds of years. Any behavior that gets positive feedback from the environment is likely to become repetitive. Any behavior that is getting negative feedback from the environment is likely to extinguish. So we really want to affirm the affirmable behavior, because this way I'm giving a better chance that this behavior will happen again. However, we need to be mindful here. We affirm a very specific behavior. We just don't tell the person, oh, you're a good person. It goes like that. Because we might have different definitions for a good person. We affirm very specific behavior. We affirm, yes, I understand it is difficult for you to stay away from drugs for 2 weeks. For most people, it would be difficult. I do appreciate you've been in remission. You haven't been using for a month, because the person is coming to you after a month of remission with a lapse or relapse, completely in disaster, catastrophic mode, and you're just changing the perception. Yes, well, you haven't been drinking for 30 days. It had never happened before. You had some problems on day 31, but you managed to stay for 30 days. That's really a big success. By affirming something that is affirmable, we are trying to increase the chance that this will happen again. Now, reflections. This is perhaps the most difficult skill and the most effective skill in motivational interviewing. When two people are talking without time constraints, without stress, without any, just normal human conversation, there are already 4 places to make a mistake. What I said, if I'm a speaker and you're the listener, what I said may not necessarily be what I meant to say. What you hear me saying may not necessarily be what I really said. What you think I want to say may have nothing to do with what I really wanted to say. The amount of errors will go exponentially when we are under stress or time pressure or both. There are lots of places to make a mistake in a counseling session and in a human conversation. One of the ways to avoid mistake is to reflect back. And this is the accuracy function of reflection. Reflect back. And in this case, you're just putting the mirror in front of the person. Here's what you just said. Is my understanding of what you just said accurate? By doing that, we are sending 2 messages. First, I'm listening, and secondly, I'm curious, I'm interested, I'm genuinely interested. It's not just the accuracy of the statement. This is a very important behavioral message. In addition to that, why do we emphasize on reflections much more than questions? Well, again, if you look at the data, if you look at the research in the last 50 years, going back to the Carl Rogers, Rogerian client-centered psychotherapy, people tend to talk more in response to reflections rather than questions. People tend to be more open and less anxious and more rational, responding to reflections rather than questions. And people tend to lie less. They tend to be more truthful. And are our patients always truthful? Okay, are we? No. It is really easy, very simplistic to tell that, well, the clients, in addiction medicine, the clients lie. Well, sometimes they don't give us really truthful information. This will be a very simplistic explanation. There is a significant major behavioral reason for people not to tell the truth. I'm not asking you to answer this question, but has it ever happened to you to lie your dentist about flossing? It's pretty common behavior and it serves certain purposes. Okay, so reflections never sound like a question. In most languages, when you say a sentence and the tone of your voice goes up at the end of the sentence, that will feel like your question. If the tone of your voice goes down at the end of the sentence, this may feel more like a reflection. You will be surprised what a different message you are sending by just changing the tone of your voice. Let me illustrate. Would you be able to help? Just simple things. I'm not going to ask you to do anything embarrassing. No, you can sit down. Please say, I want a divorce. Say it. You want a divorce? Please say, I want a divorce. So you want a divorce. How did that make you feel?
First one is, and it's eyebrow creasing or something. You tend to react to it.
So I'm attacking you. I'm second guessing. So you want a divorce? Okay. And now you're ready to fight. Right? You're in this posture. Right? How did it make you feel when I said so? You want a divorce? Did it make you feel defensive? Not really. The language is the same. The sequence of the words, thank you. The sequence of the words is exactly the same. The only thing I changed is the tone of my voice. And it gave you completely different responses, completely different messages. Reflections never sound like a question. In addition to that, unfortunately, we don't have time. We have very limited time. There is a variety of different reflections, and they serve different tools. A simple reflection means I'm just reflecting back what the client said without adding any meaning. Example, and this real example of patient of mine told me something. He said, listen, doc, I worked with this person for a long time. We knew each other with established engagement. He said, doc, listen, I understand you. I really probably need to quit drinking, but let me be truthful. I don't want to lie. It would be impossible for me because all my friends drink. We are friends for 40 years. We get together. These are my best friends. They've been around for a long time. All of them drink, and I don't think it's possible. Okay? I'm sure you've heard similar statements in your clinical practice. A simple reflection would be, yes, clearly it's very difficult for you to quit drinking. I'm not adding anything. I'm just repeating what the person said, making sure that I'm empathetic and I understood what the person said. But there is a different type of reflections. And a different type of reflections we call them complex reflections. Now I am adding meaning. I'm not repeating exactly what the person said. I'm testing different hypotheses. Imagine you have 15 doors with 15 keys. You don't know which key opens what door, so now you're trying. That's exactly what we do with complex reflections. I'm testing different responses to different hypotheses. I may use some of the so-called double-sided reflections, raising the discrepancy. So that's an interesting idea. So on one hand, it doesn't seem like you will be able to quit drinking. And on the other hand, you want to stay sober. How do you see these two things happening together? Or on one hand, you want to stay with your friends who are drinking. And on the other hand, you want to quit drinking. How do you see these two things happening together? I'm reflecting and emphasizing the discrepancy in the statement, followed by an open-ended question. In this clinical situation, I did something completely different. I use a different type of reflection. We call it paraphrasing. And my response to that, you know what, it's interesting. It looks to me your friends don't care about you. And then there was, if the patient will get defensive, I will change the strategy right away. So, oh, sorry, I probably misunderstood you. Help me understand. But in that case, he was a couple of seconds, he was quiet, and then he said something phenomenal. He said, doc, you know what? I've never thought of it this way. Baba, for the next couple of weeks, we had a conversation about the meaning of friendship, meaning of belonging, meaning of support. We didn't talk about alcohol at all. This was not the focus of the conversation for weeks before we came back to the issue. You see, by different types of reflections, you can actually, you're trying to use the key and find out what of these keys, which one will unlock the door for a meaningful conversation. Some of you may work with juveniles. And adolescents often, in clinical sessions, they often answer, I don't know, I don't know, I don't know. And it sounds like the end of the conversation, but it could be. And this could be the end of the conversation. But if you continue doing things like in a very neutral way, you know, that's interesting. You just said, I don't know, help me understand. Because there are different reasons for you to say that. I respect all of them, I'm just trying to understand. You said you don't know because you don't know and you don't want to find out. Or you said you don't know because you do know, but you don't want to talk about it. Or you said, I don't know because you don't know, but you might be interested in finding out, or maybe something else. You see, just a simple thing like answering, I don't know. Now I continue probing. This could be the end of the conversation, but it might not be the end of the conversation. You just open the door for a much more meaningful conversation. So there are avenues even here if we reflect accurately. Let me show you something. Oh, I don't have this slide for the sake of the time. Okay, so reflections is in more advanced motivational interviewing training. This is probably we spend a day using different clinical scenarios, training people how to reflect, using different types of reflections in different types of clinical contexts and clinical interactions. hopefully, one day we'll have a chance to do it with you. Now, when we talk about listening, listening is an important skill in any kind of behavioral medicine. It's not just in mine, in any kind of interaction. If you think about it, folks, we are very good in talking. We are not that good in listening. It takes 2 years for a human being to start talking and then the rest of the life to shut up. We are not really very good in listening. We can talk. And in most of our interactions, even in life, not just in clinical settings, even in life, we listen with the intent to respond, not with the intent to understand. And in clinical environment, this is a problem. And actually, this is not just our conditioning from the childhood, this is a part of our training. We are trained, listen to respond, to give advice, whatever. And in many instances, it might work, but not in our field. In our field, listening with the intent to respond instead of with the intent to understand could be a significant problem. And that could be a roadblock for the interaction with the patient that is meaningful and may lead to some results. The question is, listening for what? In motivational interviewing, there is a specific set of things that we are listening for. In every statement that our clients make, there are 2 parts. And these 2 parts are actually reflections of the ambivalence. You remember, the ambivalence is the material that the mind works with. There is so-called change talk and sustain talk. Change talk is everything that the patient says in favor of potential movement toward change. Sustain talk is everything that the client says in favor of not changing anything. They are always present, but they're present in different proportions. You may get very little change talk and a huge amount of sustain, or vice versa. You don't know. Let me give you an example. Have you seen people gold mining in rivers with a pan with net underneath it, so they stay in the cold water in the river, they grab the sand from the bottom, and then what happens? They sit, they pay attention. They let the sand go back. This is not what I'm after. I'm paying attention, but I don't need the sand. I will let it go. No goal. Okay, I will make a couple of steps left, right, grab the sand again. No goal. I will continue moving, do it again, no goal, again, no goal, and at some point, I made a step left or right or back, grabbed the sand, and I found a nugget of gold. What does it tell me? It tells me don't move. I might get more of it, because that's what I'm after. It tells stay right here. I need more of this. I will continue digging exactly the same place until I'm absolutely certain there is no more. Then I will continue moving. This is what listening in MI looks like. I'm listening all the time. I'm looking for the change talk. And when I get it, this is exactly what I will respond with reflections. This is the only thing I will respond to with reflections. I'm not ignoring the sustain talk. I'm registering, but I'm not responding to that. Do you remember that one of the words in the definition of motivational interviewing is directive? That's what makes it directive. I'm not following the client blindly wherever the client wants to take. No. I'm listening very carefully. I'm just selectively responding to some things, and I'm not responding to others. I'm not responding to the sustain talk. So using the same statement that my client made. Doc, yeah, I understand I would probably need to quit drinking. I would love to wake up sober one morning, but I don't think I can do it because all of my friends drink and blah, 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 blah. What is it that I will respond to? What part of the statement? He just gave me a piece of gold. There is some desire. Okay, that's exactly what I will go after. By reflecting, that's interesting. So a part of you really wants to quit, and that makes sense to me. Followed by the question, so should you decide to quit drinking one day, what do you think your life will look like? By asking this question, should you decide one day to do that, what do you think will happen? The real message is, this is your life, it's not my life. The second, I'm not asking you to do anything. Should you decide one day, I'm making it hypothetical. By making it hypothetical, I will diminish the defensiveness right away. And I will make the person even more ambivalent. Should you decide to stop, what do you think will happen? Okay? This is exactly what we do in MI. Listen, now I want you to see another interaction between two people.
Watch what happens as this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so. That's really a big problem. Yeah, it's pretty stressful for both of us. It gets really upset. Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so, what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here. Also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him in a lot of risk. In addition to that, the kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
I don't smoke. I've thought about quitting, but it's really hard. So I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard people tell me before. I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
Don't have time.
There's no reason why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child? I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things.
Well,
Watch what happens this time when the provider cues into what the parent is saying, empathizes.
well, perhaps the first thing this lady will do, leaving the office, will have a cigarette. She's so pissed off for you. She's so stressed. Yeah, I mean, her anxiety is true. Now, I want you to watch this interaction again between the same two people in a different way. Now, watch this time, see what kind of skills the doctor is using to work with the ambivalence. Oops.
Well, now's the time to quit. It's really gotten to the point where there's the inhaler, there's I really need you to tell me that you're going to quit smoking. This is
With the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden. I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you could tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I I've been smoking for 10 years, except when I was pregnant with him. But everything is so stressful being a single mom and like having a full-time job. And so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking is kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that. All the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what? I'm not going to risk that.
Mm-hmm.
So,
risks were so scary then that you were able to stop. Like,
yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So,
You're doing the best you can do.
yes.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Okay.
Sure.
Okay, so now I will make you work again.
So it's just, I've been smoking.
Okay, here's what we'll do next.
I will get back to the second interaction, the second conversation. Now, I will ask you, please do not pay any attention to what the doctor said. Listen only to the mom, to the patient. When you hear change talk, clap. When you hear sustained talk, snap. If you don't hear neither, just do nothing. Okay? And I will ask you to stand up because that will get your attention. Okay? So the only thing, pay attention only to what the mom says.
That's her notes.
And I will
So
help
I
you.
wrote a prescription for antibiotics for Aiden. I did want to talk to you though, I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home, so I was wondering if you could tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But everything is so stressful being a single mom and like having a full-time job, and so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing the problem.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before and stuff, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early
Getting a lot of it now.
and having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that.
So, risks were so scary then that you were able to stop. Like,
Yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to. Every new year I say, okay, this year I'm going to quit smoking. But then something happens and it just doesn't.
It's on your to-do list, it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like I know I've done it before, so I know I can do it. But at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything
More
like
and more.
that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Sorry?
It
Minus
sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempted quitting. There's different medications you can try. I don't like that. Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Right? It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life. That would be really nice. But if you're willing, then we could set up another appointment where you could come in and we could talk more about that. I would like that. That would be fun.
You see how many things you hear now when you know what are you listening for.
Yes.
And did you hear in almost every sentence, they were both sustained talk and change. Typically, traditionally trained counselors, in our education, we don't pay much attention to teach people how to listen. And they typically will miss it. But people who are trained in selective listening, they will hear it exactly the way you just heard it, what change talk is, what sustained talk. This is the verbal expression of their abilities. Yes?
Not even just the verbal, but the body language.
Everything, everything. This is very important. And now it's time for me to tell you about the S in the ORS. S is summary, and it sounds simple. You're just summarizing. You can summarize within a single session. If the person is very talkative, or if the person gave you a lot of information, you can make a summary. By the way, making a summary is a very nice way to stop somebody from talking. If you have a hypomanic patient, it's difficult to do, and one of the respectful ways to do it is by saying, listen, you gave me so much important information, let's make sure I'm not missing it. Let me summarize. A simple way to do it. Or you can summarize between sessions, depending on the context. But here's the tricky thing. In MI, you don't summarize everything. You summarize only the change talk. Imagine you're talking to a client, and the client will give you both. The client will give you change talk, will give you sustained talk in different proportions. This is a normal process. Every time the client gives you a piece of gold, change talk, it's like the client gives you a flower. You take the flower, put it on the desk, and keep listening. You keep working with the client, you got another flower, put it on the desk. You keep working, listening, working, flower on the desk, until you got enough. And then you put together all these flowers into a bouquet and give it back to the client. That's what the summaries are. We summarize only the change talk. In this interaction, do remember the doctor, the physician, at the end of the conversation, made a summary. And she made it very skillfully. She summarized only the change talk. These two ladies are my psychiatry residents. They were just kind enough to help me in taping this thing. And they're very experienced. They're very bright and very good experience in MI. And I asked the lady who played the doctor, at the end of the conversation to make a mistake, deliberately, and to see what the reaction is. And the mistake she chose to make was to start giving advice. Remember, options, counseling, chewing, and the client immediately got defensive, saying, yeah, it's nice, but I don't have time for it. This is a stage conversation. This is not a real clinical environment. In the stage conversation, this was exactly the response to when we make a mistake, the client will get defensive. Is this a bad news or good news? It's a good news. The client tells you, don't do that. Just stop it. Do something else, okay? If you need to change the strategy. Imagine you're driving and you're going from Los Angeles to San Francisco, you're driving, and your gas lamp is flashing now. What will happen if you start pounding on the gas lamp? You will break the thing, and you have no gas. It's actually, this is just the indicator that something systemically is problematic. The problem is coming. So you need to change the strategy. You need to exit the freeway, get some gas, and then you will continue. So you do something different. This is what it tells you. When the client is becoming defensive and you will sense it right away, that's actually good news. It tells you, don't do that. Do something else. It's exactly the GPS analogy. There is a tool that you may consider using with your clients is the scale. You remember the doctor is asking on a scale 0 to 10. Here's the tricky thing. You ask the patient, on a scale 0 to 10, how important is it for you to stop using drugs? 0, not important at all. 10, the most important thing in your life. Where do you think you are? Just rate yourself. And the person tells you, well, it's around 5, 6. Okay. Well, the next question is, by the way, this is an example of a very good closed-ended question.
Yes.
Yeah. The next thing you do is, okay, what made you rate the importance as 5 rather than a 2? You're going down. Because from this point further now, the client is convincing you that this is important instead of you convincing the client. And at this point, you will get a lot of change talk. Now you get a lot of material to work with. Make sense? At the same time, you may use the same scale to measure the confidence. In many instances, something might be very important for the person, but people are not confident they can actually do that. If you ask smokers, how important is it for you to quit smoking? Most of them will tell you it's very important. But if you ask them how confident are you that you can actually do that, that will be a different story. If you ask this question, how confident are you that actually you can make it? Oh, I'm not confident at all. I mean, I've tried, it didn't work. I would say maybe 2, 1.5, 2, but not more than that. Okay. What gives you the competence at 2 rather than a 0? There is some. Now the client is talking to you, giving you the reasons why. There is some confidence. Maybe not much, but there is some, because you really want to improve. Okay? Does that make sense? Yes. All right. You may see the signs of decreasing resistance and increasing motivation to do something when you recognize these kind of things. People discuss the problem less, they start more discussing the solutions, what can be done. This is a very good sign. You will get some increasing amount of change talk, and exactly these are the pieces of gold that you can work with getting more of. And you will, the person will start asking you about, okay, what do you think I need to do in this treatment? This is a wonderful question. By the way, one of the best clinical questions that I've had and I've used in my 30+ years of clinical practice is the question, what are you going to do about it? It's a wonderful question to ask patients. So what are you going to do about it? You can try. Maybe not the first time you see the patient, but kind of in the course of the conversation, this is a very good question to hear the answer. The patient may tell you, I don't know, probably. Probably that's a good place for you to start thinking about it, and we can think together. I cannot do it for you, but I can do it with you. Okay? That could be an interesting place to start some thought process and cognitive process, thinking about what can be done. All right. Okay, folks. And I really want to thank you for the work you're doing sometimes in a difficult environment, in difficult circumstances. You continue doing that. I wish you good luck. I wish you take good care of yourself and each other and your families. And we have time for some questions or comments or ideas, whatever. It's your time. Yes.
Thank you very much, Professor, for this nice presentation. It's a small question on your experience being a psychiatrist and dealing with people without insights, therefore likely to be resistant. Of course, psychologist's perspective is understandable. Yeah. What has been your experience?
What a wonderful question. In fact, the question is, what do you do with people who are not ambivalent? Right? Since ambivalence is the material that the mind works with, what do you do with people who are not ambivalent? The only thing, folks, you can do is make them ambivalent. And you can make them ambivalent by asking a simple question. Exactly the example that I gave. Should you decide one day to change this, what do you think will happen? And you will make the person ambivalent the same second. And I'm not putting any pressure on anyone. Should you decide to do it, It's your decision. But you decide to quit drinking. What do you think your life will look like? The same second the person will become ambivalent. That's exactly what I do. You don't go any further, you don't do any more. You're just trying to make the person ambivalent. Does that make sense? Okay. Other questions, comments? You must be tired. Yes.
Thank you, Professor, for the lecture.
My name is Igor. My name is not Professor.
Thank you, Igor, for this wonderful presentation. I just picked up two ways of approach from the left to play. For the first time, where the counselor was like leading the discussion, it was like I understood is playing the role of a doctor. When the doctor had to say, this is not right for one head. And then in the second play, the role of a counselor. That's to draw a line there between, that a doctor can really go straight and say, this is not head for one body. But when it comes to the counselor side, throw a ball, come to the point of finding what would you take from the two. I don't want to draw a line there. What we see the picture is the doctor. And I think it's right or it's fair for the doctor to say something is not right for one head.
So yeah. If I understood the question is it okay for a doctor to say something is not right in you or in your behavior? Difficult to answer. It depends on the context. Just hypothetically, it's very difficult to answer. Generally speaking, I would avoid doing that. I would avoid doing that because of a couple of reasons. One, probably the most important. Whatever I have to say, what you are doing is not healthy, is not right. Most likely, I'm not telling anything new to the patient. The patient already knows that. So what's the point of doing it? What's the point of doing that? Just reinforcing what we call a learned hopelessness. The learned hopelessness is a major roadblock to treatment. Oh, I've tried, it didn't work, nothing will work for me, I'm done, I'm stupid, whatever. So by just saying what you're doing is not right, most likely this is something that the patient had already considered. I would rather avoid doing that. But a lot of it depends on the clinical context.
Thank you, Igor, for the presentation. Okay, where I practice in Nigeria, we have those with addiction in the same wards as those with other mental illnesses. And basically, the ones with other mental illnesses like coach those with addiction. If you want to go home on time, just tell the doctor this, tell the doctor that, tell the doctor this. So now you're doing the motivational interview and they're giving all the right answers. Yes, I want to quit. Yes, it's going to do this. Yes, it's going to do that. But there's no emotional component to it. So how do you work differentiating like intellectual insight from emotional insights? And how do you, if the person says, I'm going to do this already, but you can feel that this person doesn't mean this, how do you then get the person to really mean it without it seeming like you don't agree with the person or you feel the person is lying to you?
Well, you know what, honestly, I'm not a big promoter of forced treatment, one-month or mandated treatment. If you look at the patients with diabetes, for instance, most patients with diabetes initially the first year after they've been diagnosed do not do what they've been told. But nobody kicks them out. We continue working with them. Most people newly diagnosed with hypertension, typically initially they don't do exactly what they're supposed to. People with substance use disorders exactly the same way. So they may give you some erroneous or untrue information. You may know that this is not true. You may ask a couple of questions. how confident are you that what you're telling me is actually accurate? You can do some probing, but at the end of the day, it's their life. You do your best, but you cannot do it for them. It's their life. There will be another opportunity to continue treatment if the person is alive. I know that I've been to Nigeria many times, and I actually activated the program in a prison near Abuja, and it's still there a couple of years ago, and it's still there. And sometimes I go back. So I know exactly what we're talking about. You can do as much as you can. One of the reasons why counselors feel so tired at the end of the day, because in many instances you do more work than you should have. Trying to solve every problem for the client, forgetting that the client is their life and the solutions are theirs. Hopefully I answer your question somewhat.
Yeah, thank you very much for the presentation. I did MI when I was in grade, but I'm just thinking now that, okay, fine, I'm attending this ICUDDR, and I want to make changes in my university. And then how do I motivate my BC and others to make a change? Because, you know, one thing I've discovered is that different sections of people make different noise. The public health physicians will be saying nutrition is important. We want to do this for everything. So I'm just thinking, it's a very good presentation. I'm just thinking, okay, fine. It was done during my ICUDDR. Okay, what can I get from it in order to push for a change in the university system? I don't know. You mentioned that you can't use MI to solve all problems. I know that. But then I'm just finding that is it, because I know that within the university system, there are certain incidences that will occur, which would make the university think about, fine, we want to make a change in this direction. So when we are hearing some kind of change talks like that, how do we fit in and make that noise?
Well, it looks to me you've done a lot of thinking already about it. And you have pretty good ideas in your mind, which avenues what might help you. So the ICUDDR, me, myself, and my colleagues, we certainly can assist you. It looks to me you approached this question in a very thoughtful way.
So what's their motivation, and how can you help solve their problem, right?
Thank you, Prof. So in addiction counseling now, are there categories of clients you can call difficult? Because like now, when sometimes counselors are making case presentations, they complain about some addiction clients. I have a feeling now after your presentation is because the counselor is not able to flow with the resistance. It's like they fight with the clients during the counseling process. So I'm wondering, in addiction counseling, are there difficult clients? Thank you.
You know, it's a wonderful question, and I'm not going into the definition of difficult clients. What I will tell you is counselors in addiction medicine, counselors and practitioners came up with a wonderful, wonderful definition to hide often their helplessness because they don't know what to do. And the definition is the patient is in denial. If you look at the literature, actually there's quite a lot of psychological, experimental psychological literature trying to define the construct of denial. And there is absolutely no evidence it does exist. What does exist is very high level of ambivalence. So the construct, the concept of denial is probably a definition, a construct that's been developed by us to avoid admitting that we don't know what to do.
Yes.
Maybe one.
Yes, let's do one more.
Thank you very much, Igor, for yet another wonderful presentation.
Thank you.
I must say that yours is not one of those presentations that someone will listen to and forget in a hurry. The one you gave in Lagos 4 years ago, I still have that here. But I also know that our brains are not as efficient as we think they are. So maybe I shouldn't direct this to you after all. Is it possible for us to get some of these materials? Not necessarily the video, but maybe in Word or whatever, so that we have gone through some motivational interviewing training before.
It's absolutely
like this, so it would be great if we could have this. Not just this, even some of the wonderful South African experience. I've spoken with them, but I'm just thinking that if we could have some of these presentations, that would be very nice.
It's absolutely possible. I made it for you. I will just find a way to provide it to you.
Email it to
Yes,
me.
the answer is yes.
Since it's on your computer, email it to me.
I will email it, yes.
And I'll post it.
It might be difficult just to make it with the videos because they're huge files. But the material itself is yours. I made it for you. You will have it. Thank you all.
I just left them out here for you to dig through, and rather than taking up your time to give an announcement. If it's missing, if yours is missing, or if we misspelled your name, we can redo it. So just let Carrie know. But thank you, everybody, and we will be in touch. And think about whether you want to be in leadership or not.